Hey, welcome, wonderful students. Hospice or palliative care? There is a difference between the two, so make sure you know the difference, okay? Again, hospice usually uses an interdisciplinary approach, so that's multiple team members, to assess and address the holistic needs of our patients and families to facilitate a quality of life and a peaceful death, neither hastening nor postponing death, meaning we don't speed it up, we don't extend it. We just literally provide quality of life and a good death. So we provide relief of symptoms experienced by the dying patient in her or his own home, or wherever they want us to meet them at, in a SNF, group home, etc. We've even had homeless patients that we've met in the field on the street to help care for patients. Patients are deemed to have 6 months or less to live, right? And we've already talked about how they can get recerted. And we must be doing frequent assessments to demonstrate a decline in health and a progression of the disease process. Basically, we have to see the patients at least once a week as nurses. We tend to see them more frequently at toward the end, but in the beginning we see them once a week, do our full head to toe, and then manage their disease and end of life. Palliative care is both a philosophy of care and an organized system for delivering cares for patients with life-threatening illnesses to relieve suffering and to support the best possible quality of life for them, regardless of the stage of the disease and the need for therapies, right? So it is literally a chronic disease management focus, right? So, again, based on quality though, not on quantity of life. So it is quality chronic disease management. So making sure that if the patient has ALS or COPD or CHF, whatever that may be, they can have a quality life still, right? And the person's expected to live a long, long time, right? This is just our every person with a chronic serious disease. So our interventions are being with the patient, as like with them. It's a journey together rather than just us being along for the journey. No, we're both going through the journey. We do not minimize our patient or family members' pain or the loss or the perceived loss. We do lots of storytelling and reminiscing about their life review. We want them to openly express their feelings, spiritual beliefs, emotional beliefs, physical needs, all of it, right? We want an open book, literally. And we are fostering realistic hope for our patients and families because because they've been given a terminal diagnosis does not mean that they cannot have an enjoyable rest of their life, right? And that's what we need. That's part of what we do to get them to see, right? Again, medical examiner, coroner cases we've talked about pretty much in detail. They have to occur. Again, if anything happens to a patient that results in their death within 24 hours, they could end up being an ME case. And all of these reasons here are listed on there, okay? And again, we've talked about it in detail on the other recordings, so we won't go in detail here. It is not our job to try to explain death in philosophical or religious terms, okay? It's just not our deal, so don't go there. We do foster an open door policy kind of thing where patients and family members can tell us anything. And we want open communication between patients and the family and use therapeutic touch when it makes sense. And if culturally appropriate, right? We definitely want to let the patient and family know that we have really specialized counselors, bereavement counselors, that can help them cope with the perceived loss and actual loss when it happens. And we need to reassure the patient and family that we are going to manage the patient physically There won't be any distress, no pain, no respiratory, none of that. And we're going to be on top of managing them. Definitely need to plan ahead for funerals. Here's learning objectives for the stress and adaptation. So again, there's physical stressors like when it's hot outside, cold outside, any kind of exposure to chemical agents. Then we have physiological stressors like a patient's pain or their fatigue, exhaustions, things like that. And then we have the psychosocial stressors of fear or anxiety, right? When we teach our patients about healthy ADLs, we're talking about getting enough sleep, getting enough rest, getting enough exercise, eating healthy, all of the support systems available to them using the stress management techniques that I talked about in the last video thoroughly, right? Our job as nurses is to identify the cause of the patient's stress and strategies to manage this patient's stress, right? That could include pain, right? It could be acute pain, it could be chronic pain. Chronic pain could be breakthrough pain, meaning the patient's on chronic pain medications, but their pain today is so much worse than it has been. It has broken through the current scheduled meds, and now we need to treat for that breakthrough pain, right? We talked about all these different types of pains in the other recordings, so please make sure that you make note cards for them and have examples of them, okay? Physiologic responses to pain, clearly, vital signs we talked in detail already. Remember the skin color, your patient's perspiration, pupil size, all of these things are going to react in response to pain. Physical signs reacting in response to pain, and that's why pain is such a negative for our patients, right? Again, nursing interventions for pain, establishing the nurse-patient relationship, which I talked about in detail before. Obviously, we're going to initiate non-farm measures along with farm measures, right? And we talked about those in detail before as well. Assessing pain frequently, teaching your patient about managing pain and improving the quality of life, right? We talked about all of that. We talked about all of that too. We talked about all of these different non-pharmacological measures, right? Side effects. So with pain management, clearly, we're going to put the patient on a bowel regimen because, like stool softeners or fiber bulking agents. Here's what I'm going to say about fiber bulking agents, though. If you add a fiber bulking agent, then you better make sure the patient understands they've got to drink at least 50 to 60 ounces of water a day, because without that, the bulking agent's just going to cause the opposite problem. There's got to be enough fluid in there for them to actually have a good bowel movement, okay? So hydration, critically important. You're also going to be monitoring the respiratory or pulmonary status, right? And always assessing for oversedation and the urinary function, right? Because you know how opioids can affect the urinary flow. So we got to be looking for that. Very important to be able to explain the difference between addiction, dependency, and tolerance, because the patient and or family may ask about those, and we talked about that in detail in the other video, so I won't cover it here, but make sure you listen to that and be able to decipher between those three. If you have a concern about addiction or dependency, or even tolerance, you're going to have a conversation with your doctor to discuss the plan. We are experts, pain experts, but always remember, if you want to get the best resource for medications is a pharmacist. They are the experts. They went to school for 8 or more years related to medications, right? So honestly, that's who I call if I want to know about meds, if these two meds are they compatible, what's the best way to run it, and all of those conversations, right? Call a pharmacist, they're great. Again, maximum safe opioid dosage has to be individually assessed, right? Because everybody's different. Tolerance develops as patients who take opioids for prolonged periods, and therefore that lends to why everybody is different as far as the maximum safe dose ranges, right? Because with tolerance, increased usage is needed to get the same amount of pain relief, okay? Dependence does occur with tolerance. Physical symptoms occur when opioids are discontinued. So the physical dependence symptoms occur when the opioids are stopped, right? Addiction, it's a behavioral pattern that is characterized by the need to take the drug for its psychic effects, right? But please know that addiction from this third line is so critical. Addiction from therapeutic use of opioids is negligible if even present, okay? So it's really irrelevant. And can involve pain management from a pain management expert, right? This is critical, important. Pain is subjective. There is no room for judgment. Do not judge your patients. It's not your job, okay? Untreated pain is a medical emergency. Watch for clues of untreated pain. Never assume, okay? And make sure pain management goals are realistic. And you're going to need to document every single pain intervention, pharmacological and non-pharm measures thoroughly. Okay, and then here are obviously our goals. Last slide is to identify the different types of pain, right? Because they're treated differently. So you need to understand those. How we use the nursing process with patients who are experiencing pain to minimize that pain, to treat it effectively, and to provide the best quality of life we can. And you should be able to describe the different types of analgesic medications, pain medications, as well as non-pharm measures that you plan to implement in your practice to ensure that your patients are safe. Okay? Thank you. This is the end of this chat.